information about all the forces that are applied to the respiratory system. There is a very nice analogy of an iceberg that really represents what forces our lungs and overall respiratory system are exposed to during mechanical ventilation. So there's the tip of the iceberg, which is the positive pressure provided by the ventilator, which is what we see on the ventilator screen, so this positive pressure. But there's also the negative pressure generated by the respiratory muscles. So the sum of these two is the total force applied to the respiratory system. If we don't measure this negative pressure generated by the respiratory muscles, we are really underestimating how much stress and strain that the lungs are exposed to. And why is this important? As I said, it can provide the injury to the lung, and then we'll see about what happens with the diaphragm. So as a reminder, these are very graphical images of what happens to the lungs during injurious positive pressure mechanical ventilation, what we call ventilator-induced lung injury. So this is a healthy lung on the left, a lung exposed to a short time of injurious mechanical ventilation, so high pressure, high volume, and then after 20 minutes, there's like really severe damage. In the original studies done by Didier Dreyfus on ventilator-induced lung injury, what they found is, as I said, those rats exposed to high pressure, high volume ventilation had a high degree of injury. But interestingly enough, if they expose those rats to injurious ventilation generated by high volume but low pressure ventilation, the injury is equivalent or even larger. How did they generate the high volume, low pressure? It's with this negative ventilation with negative pressure, like the iron lung, okay? And why is this relevant to spontaneous breathing or assisted ventilation? Because during spontaneous breathing, what the respiratory muscles do is when they contract, they change the shape and the volume of the rib cage or the whole chest wall. They generate negative intrapleural pressure, and that drives the air inside the lungs. This is exactly the same or very similar to what the iron lung does. So if we extrapolate this information to what they did in the original studies, the risk of injury to the lungs might be equivalent if we have positive pressure from the ventilator and negative pressure from the patient. Okay, this was subsequently proved in Takashi Yoshida's studies, and then the concept of patient-safe inflicted lung injury appeared. But I think this is very graphical. And then there's a risk to the diaphragm in both extremes. When we have no effort or very low effort, there is a risk of disuse atrophy, as we see in these histological samples from the diaphragm. And when there is absolutely no effort, this is blinded patients under mechanical ventilation, there is diaphragmatic atrophy as compared to normal diaphragm during short mechanical ventilation. And then when you have excessive effort, there are two things that can happen. One is the breakdown of the muscle, as we see in this electron microscopy, as compared to this very nice diaphragm. And then the other thing is that when the strong efforts are asynchronous, so this is flow, tidal volume, and this is a representative trace graph of esophageal pressure. So what happens in the pleural space, when the effort starts during expiration, this is the expiratory phase, the diaphragm contracts while it's lengthening, when it's going up. So that can potentially generate more injury to the diaphragm than normal concentric contraction, okay? So that's the risk of injury to the diaphragm. So what amount of drive and effort should we target to avoid risk for the lung and the diaphragm? Well, there is a very nice observational study that shows that patients with intermediate range of inspiratory effort. So in the x-axis, we have the magnitude of inspiratory effort during early mechanical ventilation measured with diaphragmatic ultrasound. And on the y-axis, the duration of mechanical ventilation. So those patients that had an intermediate range had the better duration of mechanical ventilation, okay? So, and then there are other studies that suggest that maybe an intermediate range of inspiratory effort might be preferable as compared to extremes, very low or no effort and very high inspiratory effort. Then we did a very nice symposium in Milan 2 years ago now, where we tried to discuss with others really brilliant minds within the field what should be the target to protect the diaphragm and the lung as well. And depending on what monitoring technique you use, we define several thresholds, okay? And I will focus on maybe two of them. So one is the reference technique to measure inspiratory effort, so the muscular pressure using esophageal catheter. I will show you in a minute. So if we want to avoid disease atrophy, we have to have at least 3 to 5 centimeters of water inspiratory effort. For P.1, we will discuss, but more than 1 to 1.5 centimeters of water. And then to prevent excessive effort, it should be less than 10-15 for muscular pressure, and then 3.5 to 5 centimeters of water for P.1. So there are many monitoring techniques. I give you this roadmap just for you to have an idea. And then if you have any of these, you can then interpret what is its specific role within the overall clinical assessment of our patients. So going anatomically, we said that the respiratory drive originates in the brainstem. There is absolutely no way to directly measure the activity in the brainstem, nor there is a way to measure the phrenic nerve activity, which is the main nerve in stimulating the diaphragm. But once the diaphragm is activated, the depolarization of the diaphragm gives an electrical signal. And this can be measured using the electrical activation of the diaphragm. There are 2 or 3 caveats about this technique. So one, be careful because it's not the actual generation of pressure by the diaphragm, it's just the electrical activity. It is very variable between patients. So we need to do some calculations to really estimate what the effort that the patient is doing when we measure this. And then if the patients are using preferentially their accessory muscles instead of the diaphragm itself, it might be a little bit misleading. Once the diaphragm contracts, we can actually look at the contraction with the diaphragmatic ultrasound, okay? The specifics about it is that it's not a continuous measurement, so you have to be at the bedside while you're performing the measurement. And we know that the effort is very variable, so it's a little bit tricky to have a overall idea of what's the effort over a certain period when you're using electrical effect, diaphragmatic ultrasound. Also, you have to have some training to properly do this. If you want to really have the gold standard for measurement of inspiratory effort, you have to insert an esophageal catheter, plus minus a gastric catheter with a balloon. With this, you can measure the actual pressure within the esophagus, which is a very good surrogate of the pleural pressure, so the pressure surrounding the lung. With this technique, this is the gold standard to measure the actual pressure generated by the respiratory muscles. Okay, and there's several calculations that we can perform using this technique. And then, on using directly the ventilator, there are 2 non-invasive techniques that can be performed. So one is P.1, P0.1, and the second one is POCC. We'll focus on these 2 on the remainder of the talk, okay? But I want you to have the overall roadmap. P.1 specifically, it's more a measure of respiratory drive than of inspiratory effort. But as I will show you later, it can be used to estimate effort. Based on what I showed you, because of the close relationship between drive and effort, measures of inspiratory effort, like diaphragmatic ultrasound or esophageal pressure, can be used to estimate the status of respiratory drive. And then measures of respiratory drive, like P.1, can be used to estimate the amount of inspiratory effort. There is one specific caveat to consider, is that when we have respiratory muscle dysfunction, there is a little bit of a dissociation between the 2 physiological variables. So you can have a patient with very high respiratory drive, but unable to perform a strong inspiratory effort. So then you might underestimate respiratory drive if you use a measure of effort to quantify drive, okay? And then focusing specifically on COVID during the pandemic, we were all very busy, proning patients and proning, etc. And we were also tired. So we had to have simple techniques to be able to screen patients at the bedside and see if our setting of the ventilator was safe and appropriate, and then adjust accordingly. So we use a lot the non-invasive techniques to monitor drive and effort. The two of them are based on the airway occlusion principle that goes as follows. As I told you, in order to generate a breath, we need to contract our respiratory muscles. That changes the shape of the chest wall, generates negative pressure within the pleural space, and this drives the air inside the chest, okay, from here to here. When we perform an expiratory occlusion, we occlude the airway. So this is not allowing the patient to get breath air in. The patient still performs the effort. There is a negative change in the pleural pressure, that equals the pressure inside the airways and the alveoli, because all of the respiratory system becomes one cavity. If we see this on the tracing, we see that this is flow over time, positive insufflation, negative exhalation. Airway pressure is the second tracing in red, and esophageal pressure is the one in green. The first breath is not occluded, it's the normal breath. Air in, air out. Then we perform an expiratory occlusion with no movement of air, zero flow. When that happens, the patient takes a breath. There's a negative deflection in the pleural space, measured in our case with esophageal pressure, but interestingly, there is also a negative deflection in airway pressure, okay? That equals the negative deflection in esophageal pressure. So without having an esophageal catheter, we can estimate what's the negative deflection in the pleural space during the occlusion. There is one caveat, is that we are not very much interested in what happens during the occlusion. We want to know what the patients do when they're breathing during normal conditions. Why I say this is because, as we see in this particular example, it is very frequent that the patient's effort might increase during the occlusion. Okay, there are two reasons for this. One is that the patient might actually react to the occlusion, and the second is that the muscles work in a more efficient condition when there is no movement of air. So based on this, there are two parameters that we measure. One is P.1. P.1 or P0.1 is the drop in airway pressure from the beginning of the effort until 100 milliseconds afterwards. So this little drop, okay? This is a very good estimate of respiratory drive because it represents our air hunger, okay? The initial steepness of this drop is really proportional to the stimulus from the brain, okay? And it's not very much affected by the capacity to generate the whole effort, okay? Because we only need to generate this very little part here to show what's our drive to breathe. And then the second parameter is called POCC, which is the whole negative deflection. So the airway pressure from here to here, okay, during the one breath occlusion. So regarding P.1 or P0.1, we did a very detailed study to validate, one, that P.1 displayed by the ventilators. This is something important to say. P.1 is displayed by most, if not all, modern ventilators. It's really, the values directly displayed by the ventilator is really a good surrogate of respiratory drive as measured by two reference techniques. So one is the rate of increase in EDI, and the second one is the rate of increase in muscular pressure measured with the esophageal pressure. So you see how it really correlates. It is different from patient to patient, but within patients, the correlation is fantastic. This means that if a patient's P.1 increases or decreases for one patient, that really means that the drive increased or decreased. The other thing that we validated is that we can have specific thresholds to detect excessively low inspiratory effort and excessively high inspiratory effort, regardless of patient's respiratory muscle capacity. Okay, so if P.1 lower than 1.1, we're very sure that that patient's effort is low. And if it's higher than 3.5 to 4, then we know that it's too high. Oh, sorry. One thing to consider is that each ventilator measures P.1 differently. There are mainly two techniques. So one is what the PV COVIDian ventilators do, which is you activate a maneuver, we see it in a video, that performs a short end expiratory occlusion, only 300 milliseconds, and really the vent measures the drop in airway pressure during the first 100 milliseconds. So it gives you the real P.1 value on that breath that you may perform the occlusion. Other ventilators, mainly the servo ventilators, they do not perform an occlusion. They just give you the value of the drop in airway pressure during the trigger phase of the ventilator, extrapolated to 100 milliseconds. What is the good and the bad? So the good thing is that it gives you a value by breath, every breath. And the problem is that it might underestimate the real value if patients' drive and effort is too high, okay? Most ventilators do the measurements like this. Going to POCC, I wanted to reinforce one concept. The value of POCC itself is not indicative of any specific parameter for that patient. You need to do a few calculations to really know what is the patient's inspiratory effort during the unoccluded breath, okay? But there is a calculator online that I will show you for you to be able to use these values clinically. Pmax is the magnitude of the effort in the unoccluded breath. And delta driving pressure, delta PL is delta transpulmonary driving pressure, is the total pressure applied to the respiratory system. I don't know if you remember the iceberg analogy. So it's the positive pressure given by the ventilator plus the negative pressure generated by the patient. So this is the risk of injury to the lung. As I already reinforced, these are the thresholds that we are currently using for low and excessive effort for P.1. For PMAS, we only use this POCC value for excessive effort. It's not very good for low effort. So PMAS more than 10, 15, and the delta transpulmonary pressure more than 15. These values we are still reviewing them and are based mostly on data known from passive mechanical ventilation. Okay. So we are going to see two videos that show you how to do this at the bedside. As I told you here on the ventilator screen, we really don't know what the patient is doing. The patient is on pressure support of 5, PEEP of 5. We think the patient is doing some effort, but no idea. Here we have a monitoring device that measures esophageal pressure, and we're really able to see here is the esophageal pressure signal to quantify what the patient is doing. So we freeze the screen and we measure here, for example, the deflection in this small breath. The patient is on pressure support. We think that the patient is doing a lot of effort, but it's only doing 3 centimeters of water, which is even close to what we do when we breathe spontaneously in quiet conditions. So if we want to estimate this low effort by using this non-invasive technique, here we activated the NIF maneuver on the COVIDian ventilators to measure the POCC. The value for that breath is 7.3 centimeters of water. This is the negative deflection. As I explained to you, we are not so much interested in that breath, but to estimate what the patient is doing in the unoccluded breath. To do that, we use an online calculator. This is the rtmaven.com. You can just do it from your cell phone, and you go to this tab of predicting excessive inspiratory effort. So we put the settings. Our patient is on a pressure support of 5 and PEEP on 5, so the peak pressure is 10. The PEEP is 5. The baseline pressure during the hold is the PEEP value, so 5 centimeters of water, and the drop we have to put the lowest value. We said it was 7, so 5 minus 7 is minus 2. And here it gives you the PMAX predicted is 5 centimeters of water. And then the driving transpulmonary pressure is 10 centimeters of water for the unoccluded breath. So this patient is breathing within safe conditions with a relatively low drive and effort. okay? If we want to measure the P.1, we activate the P.1 maneuver on the vent. The recommendation is to do at least 3 values and then do the average of the 3, because as you see, the values vary from breath to breath. So this patient has a P.1 of 1.3 as an average, okay? This is how you see the P.1 on the ventilators that give you a value breath by breath. This is not the same patient, it's a different patient. So it just gives you the value based on this little drop. Okay, let's see how these measurements look in a patient with high respiratory drive. So this patient is on CPAP. It's the same patient, we just changed the amount of support. Okay, we look at the screen, we have no idea how much effort the patient is doing. With see the esophageal pressure, this drop is 15 centimeters of water, which is much more than what our patient was doing with low drive and effort. We measure the POCC using the NIF maneuver, and you see the value 13, so almost double the value we had before. For POCC, it's also recommended to do 3. I'm doing it very often. For this one, it's a little bit better to space them out so we don't disturb the patient when we're doing it. Again, we measure P.1. Let's see, so 6.5. Look at this value, very high. 6.2 centimeters of water. And the average is 5.4 in total for the 3 occlusions, okay? So we have 2 patients, higher support, 5 centimeters of water for that patient since that it's a lot. Here, as a summary, this generates a change in esophageal pressure during each tidal breath of 3 to 6 centimeters of water. A calculated pressure time product, this is the gold standard to know the energy expenditure of the respiratory muscles, 126 centimeters of water per second per minute. This is an intermediate low amount of effort. And then based on POCC, we can estimate a muscular pressure of 5, a delta transpulmonary pressure of 10 centimeters of water. And this corresponds to a P.1 of 1.3, okay? The second case on CPAP of 5 is the patient. Change in esophageal pressure during tidal breathing is 15 to 20. This generates almost double the amount of inspiratory effort measured per minute. And this is interesting. The Pmax per breath is 10 centimeters of water, which might be potentially injurious for the diaphragm. But the driving transpulmonary pressure is the same as for our other patients. The difference is here, the iceberg has a higher contribution from the patient rather than the ventilator, okay? And the P.1 is certainly high, 5 centimeters of water. Is P.1 a valid, and POCC are valid measures of drive and effort in COVID-19 specifically related ARDS? Well, there was a very nice study, 28 patients in France. They measured P.1 on the day transitioning to spontaneous breathing, to an assisted mode of ventilation. And they found that patients with higher P.1, more than 4 centimeters of water, were associated with relapse of respiratory failure, meaning worsening oxygenation and need to adjust the ventilator settings. And they also found this with higher POCC values. So it seems that it does have a clinical meaning. There's another group that validated the use of POCC as an estimate of inspiratory effort per minute, particularly in these patients. And then I wanted to end like just showing something for you to be aware. It's not synchronous tidal breathing is not the only potentially injurious inspiratory effort. We have to be very careful and look at the tracings as well, because when we have asynchronous inspiratory effort, this might also generate an impact of patient's lung and diaphragm, and it might be a little bit more challenging to measure this using P.1 and POCC. So I don't know, Fernando, if I can pause the, let's see, the recording to show the people some highlights on the tracing. Thank you. I don't know if they see my hand. Okay, if you see my hand, Ren, and if not, I will just describe it.
Yeah, you can move the cursor, the laser pointer, and
oh, there you go.
Yep,
Okay,
and if you click, the video will play, and if you click again, perfect. The video will stop.
Fantastic. So here is, we're finishing with it. That's why I'm taking some time. So again, this is insufflation, positive in the flow, and then we have here the exhalation. So this patient is on volume control ventilation, and all the breaths are triggered by the machine. You see there's no change in the color here, and there's no negative deflection at the beginning of the breath. But we have this very clear deformation during exhalation. This represents a patient's inspiratory effort occurring immediately after the machine insufflation. The P.1 value provided by the ventilator might be misleading in this particular case, okay? And this is what we call reverse triggering, so an inspiratory effort occurring immediately after insufflation. We're still working on what's the incidence, the consequences, but we need to know that it is potentially injurious if it's excessive, okay? This is what we would see if we would have esophageal pressure. So we have insufflation, exhalation. This breath is completely passive and there is no effort. But here you see insufflation, exhalation with the same deformation that I was showing you before, and this negative deflection in the pleural pressure, because this is a patient's effort. The problems are 2 or 3. So one is the excessive effort can generate here, for example, here, double cycling, 2 breaths within the same cycle with what we call breath stacking, so double the tidal volume. And then the excessive muscular pressure can generate breakdown to the diaphragm itself, but also these eccentric contractions, because they mostly very frequently occur during exhalation when the muscle is lengthening, okay? So this is just a caveat for you to understand that within our monitoring technique, looking at the tracings, it's also very important, okay, when you start having these deformations. So with this, I thank you. I also thank some of the people that helped me doing the videos during the pandemic, and I'm ready here to answer any questions that you might have, or chat about any specific issues you might be wanting to discuss in more detail.
Thank you very much, Irene, for these great presentations. Very practical. I learned a lot of new things. Before we move into the Q&A, we have some questions already here. I want to remind everybody this is an accredited event. We will be sending you an email with information on how to download your certificate in the following hours. And before we move into asking the questions, I want to ask everybody to go to slido.com, input that number 408787 there, and tell us what did you think about the presentation. Let's see if we pass, Irene, and let's see if we see good comments or bad comments. Please be honest with us. It's anonymous. Okay, I hope to see you. Look, an excellent. We see an excellent there. And the bigger the word gets, the more times people have used that same word. Oh, it gets bigger. Awesome, excellent. Ooh, thank you very much for that. Well researched, absolutely. We like to hear that. Our events are evidence-based, okay? We are trying to get our patients to be better treated and get better outcomes. And as Irene has been saying, well, this is one of the main reasons why diaphragms get bad. And those patients, if you have seen any, which I'm sure you have, 6 months after the ICU stay, they're still struggling with their lives. So we try to do the best for those patients. Absolutely fantastic. I hope you're happy. I am, Irene. Good. We see a lot of good comments. Well, in the meanwhile, as we see this, I'm going to stop sharing now so we can talk more freely here. Let's start with the first question from Ariel Garnero. He says that's the presence of, let me move it here, that's the presence of a known autopeep makes the P01 underappreciate the drive, since the effort first need to overcome the level of autopeep in order to be sensed at the site of the measurement.
Yeah, so that's a very, very important question. So there are several caveats about both P.1 and POCC. I didn't go into much detail so that people can actually use them at the bedside, because if not, people get confused with too much information. One of the caveats about P.1 is that when you have intrinsic PEEP, the drop in airway pressure does not start at the same time as the drop in pleural pressure. It starts a little bit later. And because P.1 is so sensitive to the initial drop in airway pressure, this might generate some error in the measurement. The good news is that this has been specifically studied in ICU patients. So there are two studies, one that validated that the value of P.1 displayed by the ventilator, this was with the old ventilators, is representative of really the drop in pleural pressure at the beginning of the breath. If you measure P.1 correctly, so when the flow starts reaches 0, this is one. There is a first technical validation. Then there was a clinical validation that showed that in patients with severe COPD and intrinsic PEEP, the value of P.1 measured the way the ventilators measure P.1 can be directly used as a measure of drive and effort, and it's modified by changing the ventilator settings. So as a clinical validation. And then when we did our validation for all the ventilators, we also showed that still P.1 directly displayed by the ventilators in conditions of intrinsic PEEP are representative of the true measurement of respiratory drive measured with the reference technique to measure P.1. So there are several validations that allow us to say we can still use the P.1 value displayed by the ventilator when the patients have intrinsic PEEP. If you use a ventilator that measures, that estimates P.1 based on the trigger, this automatic breath by breath display, if the patient has intrinsic PEEP, the underestimation will be even worse. So that would be the only condition. But if you use the ventilators that perform a short occlusion to measure P.1, you should be okay, even if the patient has intrinsic PEEP.
Yeah, makes sense. This is reminding me of how many calculations I did when I was in medical physics school. It's all about pressures and formulas. I love it. Gabriel is asking, when there are low PO1 and high POCO, what could be the cause of that?
So the first thing I would check is if there's a technical issue with the measurement, because it would not be very common to have a low P.1 and a high POCC. And then the other thing is that the patient might be explicitly sensitive to the occlusion itself. So maybe patient's respiratory drive is not so high, but just whenever the patient feels the whole occlusion, then the POCC becomes a little bit larger.
Next question we have is, how about PIDs? Is there any evidence in PIDs?
Yeah, really there's not much on, for PIDs. Yes, regarding measuring respiratory drive and effort. So there are studies using EDI and esophageal pressure. So definitely it's an important topic, but not specifically P.1 and POCC. The only thing I can think of P.1 is because the volumes are so small and there is some decompression during this small occlusion. There is some decompression of air within the tubing that generates changes in airway pressure during the P.1 measurement. I feel because the tubings are smaller and the lung volumes are small, there might be some technical issue there, but it's a matter of validating it. And then maybe people ventilating kids, if they have any experience of using P.1 and they want to share it with us, that would be fantastic.
Yeah, I'm familiar of experiences, but not familiar of a lot of
No,
evidence.
studies, no.
Publications, yeah, and yeah, there are people here in the U.S. Like Jane in New Jersey, and well, many other actually who have a lot of experience, but no, there are no studies that, at least that I am aware of. Okay, we have here through Agustin Camus.
Which says that is Felipe, yeah.
He is Felipe Gonzalez, and I'm glad he's using his second last name, because otherwise he could be Felipe González Márquez, who is an ex-president of Spain. So we are not talking to the president, we're talking to Felipe González Seguel. He said, I prefer POCC and people-in-one maneuvers over PMI. But what do you think on the PMI maneuver and its utility to assess respiratory effort?
Yeah, so I didn't go into that. I just put it briefly in my map road of all the available measurements. So what he's talking about is we can perform also an end inspiratory occlusion, like the one we use to measure plateau pressure during passive mechanical ventilation, but in active conditions. Where is the rationale of doing that? When we perform this end inspiratory occlusion, at high volume, the patients tend to relax at that point. And sometimes you can see a plateau pressure, okay? Interestingly enough, if the patient has some contribution to the overall force applied to the respiratory system during tidal breathing, that means if the patient is doing some effort, when you perform this occlusion and the patients relax, the airway pressure increases more than the peak pressure, okay? But this happens if the patient relaxes and if the patient was doing some effort for that breath. What is the problem of that? There are several studies from the Italian groups, and then there is one recent study done by the Greek people, the Georgopoulos group.
Georgopoulos, yeah.
Yeah, the problem is the following: when you perform this plateau pressure during pressure support or assisted mechanical ventilation, one is that sometimes the patients do not relax. So instead of seeing the increase in pressure, you see still the negative deflection, the same that we see during the end expiratory occlusion. And really, if the pressure goes like really down because the patient is performing an effort, that's not a reliable plateau, okay? That's one problem. The second problem is sometimes the patient, instead of taking a breath in, they activate the expiratory muscles. So we see an increase in pressure that is not because of the relaxation of the muscles and the recoil pressure of the thorax. It's just the patient pushing, like the abdominal muscles pushing. And then the estimation of inspiratory effort based on that plateau pressure is not reliable. I didn't explain the last thing, the specific thing here. PMI is called pressure muscle index. And this pressure muscle index is the difference between the plateau and the peak pressure. There's this increase in pressure, which represents the contribution of the patient's effort to that particular breath when the patients are relaxed during the pause. This can be underestimated when the patient continues to have an inspiratory effort. So instead of a plateau, you have a negative drop, or overestimated if the patient performs an active expiration during the plateau. We also did a validation study that is not published yet. I would say 50 to 70% of the occlusions are reliable. You just need to look at the morphology. It needs to look like a plateau.
Right. Helen is asking for a copy of the presentation. We actually sent a handout yesterday to those who were registered up to yesterday. Send us an email and we will send it to you, Helen. Christian is saying, do we have any recommendation for COVID patients who have a lot of air hunger when we're trying to mobilize them?
So the thing I say in general, for any patient with a excessively high respiratory drive, the first point is try to ask yourself why my patient's respiratory drive is too high. try to understand and treat the underlying cause. So there, and when I say that, I basically focus on the suprapontine, so the cortical reasons for having an excessive drive. Is my patient in pain? Is my patient anxious? Does my patient have fear, which is something that we don't commonly ask? Are you afraid of something? Are you anxious?
Right.
At this point, usually patients are able to answer, if at least yes/no questions with their head. So the first thing is to try to address why my patient's respiratory drive is too high. In COVID-19 patients particularly, they have a lot of fibrosis. And then information coming directly from the lung to the brain can be the source of excessively high drive, and also very abnormal respiratory mechanics also generate higher drive to breathe, because they need to have a higher effort to overcome those loads, excessive loads. But if there's anything that we can solve, for example, anxiety or pain with medication, I would suggest to start by doing that. And if not, if there's any other cause, is there a new pneumothorax, is there, I don't know, nuclear effusion, whatever that can increase patient's drive, maybe go for that. And then it's our clinical judgment. We don't have clinical trials to dictate how to do these things yet. We are generating the evidence as we speak. So we have to be a little bit flexible. I am an advocate to have safe mechanical ventilation, try to target an intermediate range, but if the patient is tolerating a higher effort well, and this implies that the patient will be liberated faster, so we don't sedate them again, then sometimes we need to allow for a little bit of a higher drive in order to get the patient finally extubated. And I guess that during physiotherapy, this might be the case. One recommendation, and actually there is one small physiological study for physio, using, not for COVID patients, but before COVID, using proportional modes like PAV might be helpful, because patients' metabolic demands increase during physio, and then assisting them with a proportional mode that allows for increased support with increased effort might be helpful. The problem is if the drive is excessive and potentially injurious, be careful with proportional modes, because the patients will explode themselves. So that would be the only, but thinking about physio, I think that's a good advice. Try to see if proportional mode might be helpful in supporting a higher demand.
Yeah, and something I like to remember to remind people, and you actually brought up that there is a patient behind everything we're doing, which many times we forget, and sometimes asking the patient might give us the answer. So thank you for that. But one of the things that I always say is there is not a recipe. Every patient is going to be different. So what you have to do is monitor. What you have to do is assess what is going on with that particular patient, and then try to identify the best mode and the best assistance that we can give that patient for breathing. But it is very complicated if we try to make a recipe for every single patient, whether it's COVID or is COPD or any other situation. Okay, we have another question about COVID. Is how about COVID long-term ventilation in a prone position? That is a pretty interesting one.
Yeah. So we don't know yet how long to use the prone position, and in one specific context. I don't think that prone position would be advisable in long-term ventilation, but definitely yes, if the patients have any acute event. For example, the patient has been in the unit for a month or something like that, still not liberated from mechanical ventilation and gets a new pneumonia. So then I would definitely, and have like really moderate to severe ARDS, then in that case, I would strongly recommend using prone position as if it was a new event. But maybe in chronic ventilation, no. And the reason why I would say against is sometimes you need sedation, etc., to really get it while the patient has invasive mechanical ventilation, and we really want to maintain our patients as awake as possible and able to interact with physio and then recover, mainly in this very special moment of their lives, when mechanical ventilation becomes prolonged.
Makes sense, yeah. Does it matter if the waveform is in descending or a square waveform?
No, for P.1 and POCC, no, because what we're working on is with the expiratory portion of it. So we perform an expiratory occlusion, and then we see the P.1 and the POCC during the expiration. From the ventilator phase, the patient takes an inhalation, an inspiratory effort, but this is during the expiratory phase of the mechanical ventilation.
This is a very nice question that probably will give us a view of the future, okay? It says, is it possible to make the ventilator change between modes automatically according to the patient's situation?
Not that I know. So there are some, actually, well, there is one of these intelligent modes, which is, I think, Smart Care, if I remember correctly, from, I don't know which ventilator has it. And they change the settings and they perform SBTs according to how the patient is doing, but SBT meaning spontaneous breathing trials. I don't think that it changes the mode. The closest we have easily usable at the bedside are the proportional modes, but they change the total amount of support based on the patient's inspiratory.
And that's why I said that might be the future. A few systems actually do that at the moment, and it is a difficult decision to make, because changing modes actually brings liability to the system. Okay, so what if something goes wrong? So it is a complicated question to answer, Mijael. Saludos desde Texcoco, México, Dr. José Guadalberto González. Saludos para ti, de nosotros también. Have you observed a relationship between PEEP titration and level of PEEP? And Ariel says, I mean, could it be another tool to set PEEP?
Yeah, so that's a whole new chapter talking about PEEP titration. I would say two things. One, in passive condition, my view regarding passive condition, and then, interestingly enough, we have to start talking about PEEP titration during assisted mechanical ventilation, because we don't talk about that a lot, and I think it is very important. So 2 words about PEEP titration during passive mechanical ventilation. One, understand that PEEP is a compromise between recruitment, increasing the size of the baby lung and decreasing injury, and overdistension, the risk of harming the already aerated lung. How do we select the best PEEP? Do whatever you want. My suggestion is, once you select a high or low PEEP, always assess that the patient potentially benefited from that. The way I do it, I do what we call an R-to-I ratio, which measures the potential for recruitment. It's a 1 breath maneuver. I say this patient is potentially recruitable or not potentially recruitable. If it's potentially recruitable, I try to use a higher PEEP with whatever method, like express trial, whatever you want to use, higher PEEP. But always check that actually the patient is benefited from that, measuring mechanics, oxygenation, hemodynamics. If the patient is not potentially recruitable, I stick to the low PEEP, even if the oxygenation is a little bit worse. If the oxygenation is really still bad, I prefer to prone the patient rather than to increase the PEEP in a patient that is not benefiting from a mechanical perspective from high PEEP. That's in passive condition. In active conditions, one message I want to give you is that there are some patients that with a higher PEEP decrease their effort. So this is another tool that we have in patients with excessive drive, excessive effort. If the drive and effort does not improve after solving anxiety, pain, whatever, after adjusting ventilator settings for comfort, after changing maybe the FiO2 if the patient was hypoxemic, try increasing the PEEP, and there are some patients that will respond. Don't keep it at a high level if the patient did not respond. because it might be harmful, but try it and check again P.1, check again POCC, and see how it works.
Okay, let's try to sneak a couple of more questions to see if we can get it there. On a COVID ventilated patient who suddenly spikes a temperature of, let's say, 108, which is probably 39, 40, could this have further implications on the brain or pulmonary system for the future?
Yeah, so it's not the fever itself, but the systemic inflammation primes both the lung and the diaphragm for further injury. So the risk of injury is higher for the lung and the diaphragm when the patient is in a state of systemic inflammation. And the fever is just a sign that there is systemic inflammation going on.
It's the symptom.
So in those patients, you might want to be a little bit more careful and really stick to these targets of intermediate to lower, maybe in surgery.
Our own Felipe Gonzalez again is asking, what do you think on the flow index that was published by Albani recently in Critical Care to assess the level of inspiratory effort?
No, I think, so what he's explaining is a deformation in the flow, in the airway pressure tracing during the fixed flow. The thing is that we cannot, there's no ventilator that provides this value on a breath-by-breath basis. I think as a general concept, it's interesting for us to look at the flow waveform, but I think it's far away from something that can be used in clinical practice usually, currently.
Mm-hmm. Well, we are on top of the hour, so we're going to finish here. I want to thank you, Irene, for this great presentation. I'm sure it's not going to be the first and only. Well, actually, you are going to present tomorrow in Spanish for our Latin American audience, and from Spain. I hope we will see some people. I want to thank the audience again for being there in the front line of this terrible pandemic. Hopefully see you again in our in one of our following events coming. And have a great day. Irene, I'll let you finish it.
Thank you very much. Have a lovely day, everyone.
Bye.